All right. Now, if you understand the concept of perfusion, right? So if you know what perfusion is, shock is really the reverse of that, right? And it can be caused by numerous things. And if it's not corrected, ultimately, the cardiovascular system will fail. So shock is actually low perfusion, right? Which is the inability of the body to get oxygen, to get nutrients, and to remove waste and carbon dioxide. It describes a state of collapse and failure of the cardiovascular system. In the early stages, the body attempts to maintain homeostasis, a state of balance. So the body will try to preserve what we would refer to as core organs or vital organs: brain, lungs, heart, kidneys. As shock progresses, blood circulation slows and eventually ceases or stops. Shock can occur because of a medical problem or a traumatic issue, right? It can be from a heart attack, severe allergic reaction, motor vehicle crash, gunshot wound. EMTs respond to different types of emergencies to provide care and transportation. They must be constantly alert to the signs and symptoms of shock, right? So when you go out there and you respond to your emergencies, you have to be looking out for the signs and symptoms of the different types of shocks. Now, perfusion. Perfusion is the circulation of an adequate amount of blood to meet the cell's current needs. And that's a simple way of putting it, but you have to think about what is in the blood. So the blood that is circulating must have enough oxygen and nutrients, and it must be able to remove waste and carbon dioxide. The body is perfused via the circulatory system. Organs, tissues, and cells must have adequate oxygenation or they may die. And once there's poor oxygenation, we start to get ischemia. Ischemia leads to infarction. Infarction leads to necrosis. In cases of poor perfusion or shock, transportation of carbon dioxide out of tissues is impaired, results in a dangerous buildup of waste products, which may cause cellular damage. Shock refers to a state of collapse and failure of the cardiovascular system that leads to inadequate circulation. Shock is an unseen life threat caused by medical disorder or traumatic injury. If the conditions causing shock are not addressed, so if we cannot fix these issues, the patient will die. Now, in order for perfusion to be adequate within the body, there are three components of the perfusion triangle. You have the heart, which is the pump. You have the pipes, which is the blood vessels or arteries. And you have the content, which is the blood, and the blood has plasma, right? And other components. These are the three components of the perfusion triangle. If these three components are working effectively and the lungs or respiratory system is working effectively, then we will get good perfusion. If one or a combination of these components of the perfusion triangle fails, then the patient will go into shock as a result of that, right? And at this stage, you should be familiar with the circulation of blood through the heart and the blood vessels. So I'm not going to be going over that again. Now, these three parts can be referred to as the perfusion triangle. Ensure that you know the components of your perfusion triangle. The heart, which is the pump, blood vessels, which is the pipe, and the blood, which is the fluid. Shock can affect each of these components, and based on the area of the perfusion triangle that is affected, that will determine the type of shock. So if it's the heart or pump that is affected, the patient can go into cardiogenic shock or obstructive shock. If it is the blood vessels that is being affected, which is the pipes, the patient will go into a form of distributive shock. And I have 4 types of distributive shock. If it is a component, if it's the blood component, it will be either from severe blood loss or severe plasma loss, and that is referred to as hypovolemic shock, which can be hemorrhagic or non-hemorrhagic. Now, blood pressure is the pressure of blood within the vessels at any moment in time. Systolic peak arterial pressure. You don't need to remember that fancy word. What you need to remember is that the systolic represents ventricular contraction. The diastolic represents ventricular relaxation. So when the ventricles relax, right? And remember your preload and your afterload pressures. So the preload is the pressure that builds up inside the ventricles before they contract. The afterload is the pressure inside the arteries that the blood is flowing against, right? If these pressures are altered extremely, it can cause shock. Now, pulse pressure is the difference between the systolic and diastolic pressure. The pulse pressure represents how strong the heart is contracting, right? That's what the pulse pressure represents, the strength of contraction of the heart, right? So if a patient has a systolic pressure of 120/80, Miss Jackson, what would be the pulse pressure? The pulse pressure is the difference between the systolic and the diastolic. Your patient has a pulse pressure of 120/80. What would be the pulse pressure? Go ahead, Miss Jackson. If you can, use your mic, type the answer in the chat.
Can you repeat the entire question, please, so make sure I get this right?
I said you have a patient with a blood pressure of 120/80. Pulse pressure is the difference between the systolic and the diastolic. What is the pulse pressure for this patient? Go ahead. Do you understand what you need to do, Miss Jackson?
Yes, sir.
So go ahead with the answer. What is the answer? I'm gonna ask you again, Miss Jackson. Do you understand what you would need to do to get the answer?
Yeah,
Yes or no?
difference mean yes, sir.
Okay, so what is the answer? I'm waiting on you, Miss Jackson. Do you have an answer or not?
No, sir.
Okay. Miss Nesbeth, you have a patient with a blood pressure of 120/80. Pulse pressure is the difference between the systolic and the diastolic pressure. What is the pulse pressure for that patient?
40 millimeters of mercury.
40 millimeters of mercury would be correct. All right, before I go any further, let me just explain this. I am here to impart knowledge and make things clear for you, the students. If I ask you if you understand something, right? If I ask you if you understand a concept and you're telling me yes, when you don't, you're hurting yourself going forward. If you don't understand a concept, say you don't understand, right? You don't speak up when it matters, it's gonna hurt you later on, right? Because it's gonna be my assumption that you understand the concepts, right? So the pulse pressure is the difference between the systolic, that's the top number, and the bottom number. So all you're doing is subtracting the bottom number from the top number. So if it's 120/80, you're going to subtract 80 from 120. So that's 40. The normal pulse pressure for an adult is between 40 to 60 millimeters of mercury. If it's over 60, the patient is at risk for stroke. If it's below 40, the contraction is too weak to pump blood out to the rest of the body. That can be an indication of decreased cardiac output, which is shock. A pulse pressure less than 25 millimeters of mercury may be seen in patients with shock. Blood flow through the capillary beds is regulated by the capillary sphincters. These are muscles that are stimulated by the autonomic nervous system, right? So they are the our blood vessels are never ever fully open, right? If our blood vessels were fully open, we wouldn't be conscious. So the body adjusts the diameter of the blood vessels based on the activities or the type of environment that we're in. And that is the capillary sphincters. They are controlled by the autonomic nervous system, right? And that would be the section that produces noradrenaline and adrenaline. Capillary sphincters respond to other stimuli, so they can respond to heat, they can respond to cold, they can respond to the need for oxygen and waste removal. Perfusion requires more than just having a working cardiovascular system. Adequate oxygen exchange in the lungs must occur. We talked about that earlier. Adequate nutrients in the form of glucose in the blood. Adequate waste removal, primarily through the lungs. Mechanisms are in place to help support the respiratory and cardiovascular system when the need for perfusion of vital organs is increased, right? So when there's an issue with perfusion in the body, the autonomic nervous system will go into action to try and maintain perfusion to the core organs. Hormones are triggered when the body senses pressure falling, right? And the first place that the body picks up that the blood pressure is too low or the pressure is too low is the kidneys. Now, this will cause an increase in heart rate. Once blood pressure falls, heart rate will increase to compensate. So there will be an increase in heart rate, strength of cardiac contraction, and peripheral vasoconstriction. All of these changes are occurring to maintain a pressure to supply the core organs with blood. That's the end game when the body goes into shock. That's all the body is trying to do. It's trying to preserve the core organs. And by doing that, we will start to see the signs and symptoms of shock in the patient's presentation. Together, these actions are designed to maintain pressure in the system and sustain perfusion of all vital organs: brain, lungs, heart, kidneys. It is this response that causes all the signs and symptoms associated with shock. Now, causes of shock. Shock can result from bleeding. That would be hemorrhagic shock. It can result from respiratory issues, acute allergic reactions, severe reactions, and overwhelming infection. Damage occurs because of insufficient perfusion of organs and tissues. All right, so with the perfusion triangle, if it's the pump, as I said earlier, the shock will be either cardiogenic in nature or obstructive shock. Obstructive shock means that the heart is indirectly being affected. It's not directly being affected, but indirectly. Something is blocking the heart from pumping properly. For fluid, it would be either from severe blood loss or plasma loss. So we're talking about severe bleeding or vomiting and diarrhea, excessive vomiting and diarrhea. And this would be hypovolemic shock. Or if it's a blood vessels, it's a distributive problem. Something is occurring in the body that is causing the blood vessels to open up too much, right? And if the size of the blood vessels increase, we're talking about the volume increasing, right? That space, if that space increase, the pressure inside of the blood vessel is gonna drop. Yes, Miss Nesbitt.
Sir, why would infection be a cause of poor vessel function? What's the rationale?
When we get to septic shock, I'll explain it. So that's septic shock. I'll go through that one. But that's a good question. We'll get to it. No worries. All right, so pump failure, you have cardiogenic shock, which is direct damage to the heart, or obstructive shock in the form of a tension pneumothorax, cardiac tamponade, or pulmonary embolism. Then you have poor vessel function, which is distributive shock, which can be septic in nature, neurogenic in nature, anaphylactic in nature, or psychogenic, right? So you have 4 types of distributive shock. Then you have low fluid volume, which will be either hemorrhagic, that means excessive blood loss, or non-hemorrhagic, meaning dehydration through excessive sweating, excessive diarrhea, excessive vomiting, where the plasma is lost. Now let's look at cardiogenic shock. All right. Now I don't want you to SWOT, that cardiogenic shock is the heart. We need to understand the concept. All right, so let me see if I can do some drawing. Let's see how much my drawing skills have improved. Everybody seen my diagram?
Yes, sir.
All right, so what I just drew, think of that as the coronary arteries, right? So that's the coronary arteries, the artery that supplies the heart muscle directly with blood. Now, over time, if we don't eat properly, we start to get fat building up in the walls of the artery, right? So we start to get fat building up. Now, what happened to the space inside of that artery? What has happened? Which bright spark can tell me that? What going on with the space? Yes, Miss Johnson. Go ahead.
The space will become smaller, so you'll have a smaller amount of blood pumping to through the coronary artery.
Or you can have increased pressure, right? Atherosclerosis. All right. Now, when it's fat or cholesterol building up in the walls of the artery, that fat buildup is referred to as atherosclerosis, right? Now, as you rightfully said, the passage will become narrow, right? But if the heart is still pumping okay and the blood volume is okay, what will happen is there will be increased pressure. So this patient's blood pressure is gonna go up over time. So they will develop hypertension over time. Now, what will happen over time is you'll also find that over a period of time, this now starts to harden. So it starts to harden up, right? All of this start to harden up. So it's no longer fatty, it starts to harden up. Right now, when it starts to harden, this is what we call arteriosclerosis. So this would be arteriosclerosis. That's the hardening. So atherosclerosis is the fat buildup. Arteriosclerosis is the hardening. So the patient has a narrow diameter in the coronary artery. Over time, it started with fat buildup, but over time it hardens. And then one day, what is going to happen is the pressure is so high that it rips off a piece of this plaque, and then we have an obstruction, right? So now the artery is blocked. What has happened to this patient? Which bright spark can tell me that? What this patient have now? Yes, Mr. Jennings.
This patient would have ischemia in the coronary artery, and then that is basically as a blockage. So the blood does flow into the coronary artery, which is supposed to supply the heart muscle. And not supplying
Okay,
the blood.
you're kind of correct, Mr. Jennings.
Okay.
Ms. Nesbitt.
Um,
Nesbitt, go ahead.
Sir, this is what is known as an emboli, which is that plug off thing that breaks off and occludes
Right.
the artery.
Right, the patient has a clot in the artery. Now, what is that? What is that? Ischemia leads to what? What does ischemia lead to?
Infarction.
Good. So the ischemia would start from the narrowing of the coronary artery. Infarction is when there is a blockage, right? So the patient now have a clot in that area. They have a myocardial infarction, right? No blood flow is going to that area of the heart. So the cells in that area will start to die. So this patient has a MI or a heart attack. All right, so we have gotten to that point. Let me get back to my slide. It is chapter 12. Yes. The patient now has an MI, which is bad, very bad for the patient. All right, so let me get back to that slide. Now that you understand that concept, we can look at cardiogenic shock. Now, anytime a patient gets a MI, right? Anytime a patient gets a heart attack, three things can occur from that heart attack. One, the patient can go into sudden death within 2 hours, meaning the patient goes into cardiac arrest within 2 hours, right? Where the patient will need CPR and the use of an AED. So that's a possibility. The next possibility is the patient can go into congestive heart failure. And congestive heart failure can be either right, they can have extreme right issues or extreme left issues. If it's extreme right, they will get fluid building up in the legs, the liver, and the jugular veins. That's right side heart failure. If it's left side, they will have fluid building up in the lungs. That's pulmonary edema, right? So the patient can get congestive heart failure. They can get it with a high blood pressure, they can get it with a low blood pressure, right? So the first thing that can occur, or you should be thinking about, is the possibility of sudden death within 2 hours. You should be thinking about congestive heart failure. And the third is the patient, the ventricle is so damaged that it loses 40% of its cardiac output. And that is what we would refer to as cardiogenic shock. So cardiogenic shock is when the heart is so badly damaged that it loses 40% of its cardiac output. And I like to tell students, think of it as a patient having a heart attack with a low blood pressure. So the patient has a heart attack and the blood pressure is very, very low, right? That's cardiogenic shock, right? And remember, if they develop CHF or congestive heart failure, it can affect either the right side or the left side. If it's the left side, they will get pulmonary edema or fluid in the alveoli. If fluid is in the alveoli, respiration will not occur, right? And that's the exchange of oxygen and carbon dioxide. Pulmonary edema leads to impaired respiration, which may be manifested by an increased respiratory rate and abnormal lung sounds. You would definitely hear crackles when you listen to this patient's lung sound, which is an indication of fluid in the lungs. What type of treatment would this patient benefit from if they are able to follow commands? Which Bright Spark can tell me that. So if this patient is having cardiogenic shock with signs of left side heart failure, pulmonary edema, what device this patient could benefit from? Who can give me an answer to that? Go ahead, Miss Nesbeth.
A CPAP device.
Good. This patient would benefit from CPAP, continuous positive airway pressure. Excellent, excellent. Cardiogenic shock develops when the heart cannot maintain sufficient output to meet the demands of the body. In other words, the heart is so badly damaged that it cannot stretch effectively. And if it can't stretch effectively, your preload pressure will be low. If the preload pressure is low, cardiac output will drop, right? So we can no longer sustain the vital organs and the peripheral areas of the body, right? Now, if the body is not able to create a pressure to sustain vital organs and peripheral areas, what would the body do? What is the body going to do about that? What is the decision that occurs at that point? Which bright spark can tell me that? We're having an interactive session today. Yes, Mr. Jennings, go ahead.
Would it start to constrict the vessels in the peripheral areas of the body to try and keep blood flow to the vital organs or the trunk of the body in adequate volume, I guess?
That would be correct, right? So the body is going to say, okay, what is more important? And the brain, heart, lungs, and kidneys is more important. So the body will constrict the blood vessels in the peripheral areas and open up the blood vessels in the vital areas, right? Now, if the blood vessels are constricted in the peripheral area, what would happen to the temperature of the skin? Go ahead. Well, take on the time, take on the time. Miss Johnson, go ahead. Go ahead. I saw several hands. Yes,
The,
Miss
the,
Johnson.
the, the temperature in the skin would drop, so the skin would feel cool.
Right. So you're gonna start getting a cool temperature of the skin, right? Because heat travels in the blood. That's what you were going to say as well, Mr. Jennings.
Yes, sir.
Okay. So we're on the same wavelength. We looking sharp this morning. We're looking sharp. All right, so that's one. Now, if the body is constricting the peripheral vessels, what is going to happen to the color of the skin? So we just talked about the temperature. What is going to happen to the color of the skin? Go ahead, Mr. Jennings.
The skin would start to look pale due to the decreased
Good.
blood flow.
Right. The skin is going to get pale, and if there's a oxygen deficit, eventually that pale skin will turn to cyanosis. Now, why am I asking you all of these questions? The reason is I don't want you to SWOT the signs and symptoms. I want you to understand the pathology of the problem. If you understand the pathology of the problem, then you know what signs and symptoms to look for. You don't have to SWOT them, right? Now, if the cardiac output drops in the body, meaning the blood pressure falls, how is the body going to compensate for that low blood pressure? What would the body do to compensate for that? Mr. Jennings, hold on. Miss Jackson, your time. Your time, Miss Jackson.
Can you repeat the question, please?
If the cardiac output falls, the cardiac output falls, that means the blood pressure is low. How is the body going to compensate for that low blood pressure?
The heart is going to speed up, like it's going
Okay.
to. Yes, sir.
All right. Miss Nesbit, go ahead. Miss Nesbit, your time.
There will also be an increase in the respiratory rate from the phrenic nerve stimulation.
Yes, respiration would increase, and you will get the blood vessels constricting to increase pressure, right? So heart rate would go up, respirations would go up as well. Good. Now, if the core organs like the brain is not being properly perfused because of the poor cardiac output, what would you expect to see in the patient's level of consciousness? Would you expect this patient to be alert and fully oriented? Go ahead, Mr. Jennings.
So, with the decreased blood flow to the brain, the patient would you would start to see signs of an altered level of consciousness. The patient may look disoriented and confused.
Right. So once the body is not able to compensate effectively, you will start to see changes in the mental status. Good. All right. So you're with me so far. Cool. So that's cardiogenic shock. Now we're still on the pump, but we're looking at obstruction now. So obstructive shock caused by mechanical obstruction that prevents an adequate volume of blood from filling the heart chambers. 3 examples: cardiac tamponade, tension pneumothorax, pulmonary embolism. Right now, a cardiac tamponade will result primarily, this is not the only way, but most common cardiac tamponades will occur from penetrating trauma to the chest. Doesn't mean that that's the only way it can occur. Now, what happened with this penetrating trauma is the blade went through the pericardial sac. That's the membrane around the heart. And when it went through that membrane, bleeding starts to occur. So there is bleeding occurring in that space between the membrane and the heart muscle, right? So blood start to fill up in the pericardial sac. Now, if blood is filling up in that sac, naturally, it's going to affect the ability of the heart muscle to expand, right? So that blood is indirectly affecting the heart muscle, right? So it's obstructing the heart muscle from expanding. Now, if the heart muscle cannot expand, can it fill properly? Is it going to fill up okay? Certainly not, right? So if the heart muscle cannot expand effectively, it cannot fill with blood. If it cannot fill with blood, it cannot push adequate amounts of blood out to the core of the body and the peripheral area. So there will be a drop in cardiac output or shock. This is known as an obstructive shock. Now, let's think about the patient's presentation. Would you expect this patient to have a high or low blood pressure? Talking to you now. Anybody? Would you expect this patient to have a high or low blood pressure? Yes, Mr. Jennings.
Based on the decreased cardiac output, I would say that the patient would have a low blood pressure because the vessels are still in the same state.
Right. Yes, Miss Nesbit, go ahead.
Sir, I'm looking at it a little different from Mr. Jennings in that the fact that the ventricles cannot contract as it should, it would lead to weak ventricular contraction. So the pressure in the aorta would be less. So that's why the blood pressure would be less. that can work too?
Yep, it's the same low cardiac output, both are on the same page, right? Both are on the same page, right? So the problem, what I want you to understand is that the problem is with the heart indirectly, right? But we're still on the heart. Nothing is wrong with the blood vessels. Nothing is wrong with the volume of blood. The problem is with the heart. Now, if the heart cannot stretch to fill with blood because of that blood that is inside of the pericardial sac, where would we get back pressure? Where are we going to get back pressure? Yes, Mr. Jennings.
I think you would get it inside the veins as well as inside the lungs, because the obstruction is preventing the whole heart from expanding. Does that make sense?
Good. Yeah, more so on the vein side, right? So you will definitely be looking for distended neck veins in this patient. Yes, Miss Nesbitt.
Sir, that's exactly what I was going to say, the jugular vein distension.
Right. You're gonna be looking for jugular vein distension, right? So that's a sign that you will look for. Would you expect this patient to have a normal heartbeat? If you listen to this patient's heartbeat, would you expect it to be normal? Would the heartbeat be normal? Miss Jackson, would this patient have a normal heartbeat?
No, sir.
Okay, good. All right, so you're looking for a deficit in the blood pressure, you're looking for distended neck veins, you're looking for muffled heart sounds, right? Beck's triad, that's what it's called. So that's your cardiac tamponade and how it can cause obstructive shock. Now let's look at the tension pneumothorax. Tension pneumothorax. Let's go back to the whiteboard. I hope I can draw this. All right, so this is a lung. This is another lung. Right? And we have the connection going up. Right? And all right, everybody seen the diagram of the lungs? Yes?
Yes, sir.
Yes, sir.
All right, good. Now, when you did your anatomy and physiology, you learned that the lung has a membrane, right? It has an inner and outer portion to this membrane. One that attaches directly to the lung tissue itself, and a portion that attaches to the cavity. Now, one of the common causes of a tension pneumothorax, it doesn't mean that this is the only way it can occur, but one of the most common cause is going to be excessive blunt force trauma to the chest. So let me paint a picture. You have a patient is driving a motor vehicle, lose control of the vehicle is about to crash, frontal collision. At the before the point of impact, so the front portion of the vehicle hit an object, it caves in, the interior of the car starts to cave in on the patient, and the steering wheel is about to hit the patient's chest. Now, before the point of impact to the chest, the patient holds their breath, right? So they hold the breath and the glottic opening closes. So there is air trapped in the lungs. When the steering wheel caves in on the chest, we get what is called a paper bag effect, right? So in other words, the lining of the lungs ruptures. So there is an opening now in the lining. Once that opening is larger than the actual air passage, when they breathe in, instead of the air going into the trachea, it goes into the lining and it starts to compress the lungs, right? So it starts to compress the lungs. The lungs starts to get compressed. And this is what we call a pneumothorax. So there is air compressing the lungs. Now, what is the space between the lungs referred to as? What is that space called? Who know that? What is the space between? Yes, Mr. Jennings.
Is it the pleural cavity?
No, the space between the lungs. Next up, who wanted to try? Miss Johnson. The space between both lungs. What is that space referred to as? Comfort, Miss Johnson, where art thou?
Sir, I don't remember.
Okay, okay. Miss Nesbeth, what is that space called? It's a very important space. Comfort, Miss Nesbeth. Go ahead.
Sir, is it the potential space? I don't remember, sir.
Yes, Mr. Jennings. Go ahead, Mr. Jennings.
I was going to say that the thoracic cavity. Short, sir.
No, no, no. The space between the lungs is referred to as the mediastinum. So that is the space where we have the heart and the major blood vessels and the esophagus. Now, what is going to happen is if the air that is inside of the pleural membrane, if that air is not removed, eventually the membrane will start to expand. Everybody see what's happening now? It is now starting to create pressure on what? It's now restricting the movement of the heart, right? So a pneumothorax is a collapsed lung. A tension pneumothorax is when the lining starts to expand to the point that it is now obstructing the heart, right? Now, if the heart can't move effectively, the heart cannot stretch effectively. If it cannot stretch effectively, it cannot fill up with blood. If there is not enough blood going into the heart, then there will be less blood coming out of the heart. So cardiac output is going to decrease, right? And the vital organs, more important, so the body is going to try to redirect blood flow to the vital organs, right? This is what we call a tension pneumothorax. Now, because the lungs is collapsing naturally, if you listen to this patient's lung sounds, they will not have good lung sounds. They are going to have diminished lung sounds, right? There will be also back pressure in the neck veins. Now, what can happen as well, and this is in severe cases, it gets so bad that the trachea starts to shift from its normal position, right? So it starts to shift to the unaffected side. If you see that, your patient is close to death. So if you see a deviated trachea in a patient with a collapsed lungs, they don't have a lot of time to live. right? Now, if you get this type of call in the field, tension pneumothorax, which ultimately leads to obstructive shock, you will need to request ALS, right? If you don't have ALS available, the patient needs to get to the hospital as soon as possible, right? Now, what the paramedics would do is they would do something that is referred to as needle decompression, where in layman terms, we're inserting a IV catheter, a large IV catheter into the chest to decompress the ear, right? So you insert the needle with the IV catheter, pull the needle out, leave the catheter in, and the ear will be released from the pleural space. It does not fix the problem. All it is doing now is easing pressure. So the needle decompression only ease the pressure off the heart. It does not fix the collapsed lung. Yes, Miss Nesbeth.
Or is this the technique that you see in the shows with the pet when they insert the pen? Is that it?
Not as dramatic as in the shows, right? Because it has to be inserted in a specific space. It has to be the second intercostal space. So in the movies, you just see them jam something in the chest. It doesn't work like that. You have to search for a specific point, and then insert it. Yes. So this will relieve the pressure of the heart and buy time for us to take the patient to the hospital. Eventually, the patient will need a chest tube. So that is what is going to reinflate that lungs. And that is a tension pneumothorax and how it causes obstructive shock. Now, let's get back to our slides. Now, the last condition that will cause obstructive shock is a pulmonary embolism, right? Now, an embolus is a clot that travels. An embolus is a clot that travels. A thrombus is a clot that forms in the area. Ensure that you understand the difference. So an embolus is a clot that travels. A thrombus is a clot that forms in the area, right? Very important for you to understand that concept. Now, I mentioned to you previously, common cause of a cardiac tamponade is puncture wounds. Common cause of a tension is blunt force trauma to the chest. Don't mean that these are the only things that can cause it. A common cause of a pulmonary embolism is usually from a patient who is recovering from surgery to the lower extremities, right? So this patient recently did surgery on bones or somewhere in the lower extremities, and they are bedridden and not moving often, right? Now, because of that, a clot, a thrombus, forms in the area, right? A clot forms in the area. That's a thrombus, right? And they suddenly move. So they haven't been moving a lot, and then they suddenly move. And what happens is that clot is dislodged. And when that clot dislodges, it starts to travel. Once it starts to travel, it now becomes an embolus. And it's going to travel in the venous system, right? And if it's traveling in the venous system, which side of the heart would it end up? Yes, Mr. Jennings.
On the right side.
Good. It's going to end up in the right atrium. It's going to pass into the right ventricle, and then it's going to go up into the pulmonary artery. And when it ends up in the pulmonary artery, it will either block the right and left at the same time. So it's either gonna block the right and left pulmonary artery at the same time. And if that occurs, the patient immediately goes into cardiac arrest, and the blood flow would be completely cut off. If it's a partial blockage, they will get what we call a pulmonary embolism, right? So what is happening is the blood that is now leaving the right side of the heart to go to the lungs is reduced. So indirectly, the heart is being affected, right? Now, if less blood is going to the lungs, it means less blood will return from the lungs, right? So less blood would return to the left side of the heart. So we have less blood going outside of the heart. So the patient will have a low cardiac output or obstructive shock. Because it's a pulmonary embolism, the patient is definitely gonna have difficulty breathing, right? You're gonna see cyanosis in these patients. Oh, and when you give them oxygen, the cyanosis does not improve because there is a blockage, right? There are other things that can cause a PE. We won't go into it too much right now. So that's a pulmonary embolism and how it can cause obstructive shock. Yes, Ms. Nesbitt.
Sir, I'm just looking at the real case scenario. We have responded to a patient. Patient is having a pulmonary embolism, which is,
Yep.
sir?
Go ahead, go ahead.
Right, sir. I mean, the patient is there. We have done our assessments and whatever. By the time that the patient won't respond to oxygen, don't you think that that's a sure death right there by the time we reach the hospital, sir?
Nope. Just because the patient is not responding to the oxygen don't mean that the patient doesn't need the oxygen. Yes? So we need to have oxygen going into the body. And one of the first signs and symptoms that this patient is going to have is sudden difficulty breathing, and they will start to cough up mucus with a pinkish color. They will need oxygen. Give it to them, right? Just understand that because there is a partial blockage, the cyanosis might not improve, right? But they need the oxygen. They're gonna need it. And it's not guaranteed death, right? It's not guaranteed death. What would be guaranteed death is if it's not recognized early. So if they don't pick up that it is a PE early, then death is guaranteed, right? But I've had PE patients in the field and the patients survive, right? Overseas and here in Jamaica, right? And the patient that I had that had a PE was from contraceptives. Right? It was from the contraceptives that she was taking. Yes.
Sir, the issue with the superintendent, sir, who died recently at the KPH, would you diagnose, well, based on just raw material, sir, that was a PE, sir, based on the fact that it was aggravated by sudden movement? And I'm thinking, if the hospital couldn't manage it like that and he died and he was at the hospital, it's just that the chances are so slim with us in the field, sir. That's what I was thinking about.
First of all, remember that I am being recorded. So I have to be very diplomatic in my responses. I cannot say if it was a PE. I was not there physically, right? What I do know is that, as I've said earlier, if we fail to pick up, so if a patient in the hospital is having a PE and it is not picked up early by the doctor, then yes, the patient can go into cardiac arrest depending on how severe that blockage is, right? If it is recognized early, like for the patient that I had, the patient was complaining of chest pain, right? So the patient presented with chest pain. She wasn't having any difficulty breathing, just chest pain. She didn't have a cardiac history, and after drilling her, I found out that she was on birth control pills, and then pop in my head that some of these birth control tablets can cause clots. And when I did the ECG, I could see changes on the ECG that were linked to the possibility of a PE. I was able to notify the receiving facility early. Patient got there. She was given thrombolytic therapy and she recovered perfectly fine, right? So the issue is when it is not picked up early. If you don't pick it up early, then the patient can certainly die, because not only do they have a problem with the blood leaving the heart, they will have a severe breathing problem as well. They're going to have trouble breathing. So I don't know if that's the reason that the superintendent died. I would have to be there, right? I would have to be there. All right, so let's review. Cardiac tamponade, collection of fluid between the pericardial sac and the myocardium, right? Now, pericardial effusion would be small amount of fluid, tamponade, large amount of fluid, right? The more fluid we have in the sac, the harder it's gonna be for the patient's heart to move. And this problem can only be fixed in the hospital setting, right? Now, as a paramedic, I was taught the procedure, right, which is a pericardiocentesis. I was taught that procedure as a paramedic, but I would never do that procedure in the field. So literally what you're doing is you're advancing a needle, right? You're advancing a needle under, just at the tip of the sternum, under the sternum towards the left shoulder. And you advance that needle into the sac and then pull the blood out of the sac. And once the blood is removed or the fluid is removed, it eases the pressure of the heart, right? And it don't take a lot of fluid to cause complications with the heart. Caused by blunt or penetrating trauma, more common with the penetrating trauma. Signs and symptoms are referred to as Beck triad. So that's distended neck vein, low blood pressure, muffled heart sound. Tension pneumothorax caused by damage to lung tissues. The air normally held within the lungs escapes into the chest cavity. The lung collapses and air applies pressure to the organs, including the heart and great vessels. So the heart is indirectly affected by the expansion of the pleural lining. That's tension. So it does not become tension until pressure is created on the heart. If there is no pressure created, it is simply a pneumothorax. Then you have the pulmonary embolism, a blood clot that blocks the flow of blood through the pulmonary vessels. If massive, can result in complete backup of blood in the right ventricle, leads to catastrophic obstructive shock and complete pump failure. And that's the obstructive shock. All right, take a 15-minute break. And when we return, we will go into distributive shock. 15 minutes.